Now we have Dr. Annie Sreedhar. She's the HOD of Oculoplasty Department in LF Hospital, Angamali. She's a pioneer in establishing oculoplasty in Kerala. She is the first one to start oculoplasty practice, and we follow her. Ma'am, please stand.
Yeah. So, so why do we do socket? When do we do socket reconstruction with the mucous membrane graft? When we have a surface contracture. So this increases the surface area of the socket, and you can deepen the phonesis. And also when the socket is unable to retain the artificial eye between the lids. And also when you have a foul smelling discharge in the socket to do earlier skin graft done, usually earlier plastic surgeons used to do skin graft. That's a very foul smelling discharge. You have to remove the skin graft as far as possible and then put in a mucous membrane graft sometimes. So you have to undermine the conjunctiva. You have to create the phonesis, new phonesis. So you have to undermine the conjunctiva up to the orbital margins till you feel the bone. You just go under the conjunctiva and put bolsters in the phonesis which come out through the skin, and these bolsters come out through the skin, and then you tie them over the skin. So the phonesis are deepened. So I selected this patient who had she had an eye enucleated and EBRT, external beam radiation, done at the age of 2 years. And she had a hemiatrophy of the face, a sunken orbit. There was a bony contracture and a surface deficiency, and phonesis were shallow, and you can see the conjunctiva was dry and fibrous, even thicker than the normal skin. I selected this case because the vascularity will be low, and we can see the whole thing unimpeded by the blood. So you can see the skin is so thick, and it was not cutting with normal scissors. I had to use a blade. She actually, in this case, stick-on prosthesis or a spectacle mounted prosthesis would have been better, but she wanted a artificial eye to be placed in the socket. So after deepening the undermining the conjunctiva, scalpel set pieces are used as bolsters for the upper and the lower phonesis. You can measure the pieces by placing them on the phonesis. And then 3 sutures of 3-0 ethibonds are placed on the bolsters and then taken out with a cutting needle through the skin. So here you have to keep in mind that the lower phonesis are about 10 to 15 millimeters deep, and the upper phonesis are about 20 to 30 millimeters deep. So you are creating new phonesis. These are taken out through the skin, 3 such sutures. So when you keep the bolsters inside, it will form a uniform, there will be uniform depth of the phonesis. And then over 3 small pieces of scalpel set again. To prevent cut through of the skin, we tie them over the lids. Now again similar procedure is followed for the upper lid. These sutures are taken out after, and the bolsters, sutures and the bolsters are taken out after 2 weeks. Here you can see that the original conjunctiva of the patient covers only the one part of the lid. The whole of the bulbar conjunctiva has to be replaced. For this patient, I did a dermis fat graft, then that didn't take, so I think mucous membrane grafts 2 times. So now the video will go on to how to take a mucous membrane graft. So here you have to keep 5 millimeters inside the vermilion border. The vermilion border is a border that you see on the lid, and you have to keep away from the frenulum. And the maximum size of graft is 2.5 to 3.5 millimeter that you can take, and the lower lip. And the side of the cheek you can take a larger size graft. So here I am sitting at the head end of the patient and operating under a microscope. So you will see an enlarged view, very enlarged view, I think. So give a block under the mucosa slowly, and then put the lower incision first so that the blood will not impede your view of the upper incision. And the socket, you need not take a thin graft. You can take a little bit of fat, it's okay. And then make holes in the graft so that you can pull it and increase the size of the graft. And you need not suture it to the edge of the conjunctiva. Sometimes you cannot get the edge of the conjunctiva, you can just suture it to the bed. So you can see how much you can increase the size of the graft. And the middle and lateral canthi should be sutured meticulously, because there again bands can form, preventing the placement of an artificial eye. So after socket reconstruction, you should always put in a custom artificial eye. Never go in for a ready-made eye, because this can produce again contracture, and it's very difficult to redo a socket because all the fibrosis happens. So it's very difficult to do a irradiated socket. So after placing a gauze piece, sometimes I don't do it, and then place a conformer, and you should always see that the conformer is placed horizontally and under the bolster. Again, if the conformer is not placed horizontally, it can again produce a contracture of the new phonesis that you have done. Always do a custom artificial eye, you can see the difference. And this girl had an eye put in later. The lids had to be painted over the artificial eye by Shiji, our ocularist. So thank you. This girl developed Fairuz. This girl later developed 1 or 2 years later. She developed a swelling over the forehead. It was an osteosarcoma after irradiation. So I think we lost her. After the putting in artificial eye, she got married. She had a child. She got the job, but after that she survived. I know. Thank you.
Thank you, ma'am, for the presentation. And one thing we really look up to Annie ma'am is that she's so fearless and daring. She always takes up the toughest case and fearlessly does the case. That's something we learn from her. She's